At the outset, I would like to thank Dr. S Srivastava and the organizing committee for this wonderful conference, for this great opportunity to be connected with you. So, the topic of my discussion is the significance of the thoracic inlet status in cervicothoracic deformities, as this is one area which is often neglected in our assessment of patients. When you see major deformities are like this, either in the cervical region or in the cervicothoracic region, we know that there is a lot of issues like issues concerning body image, general function, neurology, and also the high mortality and morbidity that may be associated with surgery. And one of the reasons for this is pulmonary dysfunction. And for pulmonary dysfunction, we always try to correlate it with uneven trunk growth, the narrow and distorted rib cage, the location and magnitude of the curve, which all leads to a loss of the vital capacity. But rarely do we actually see or talk about or evaluate one of the other important anatomical regions, that is the thoracic inlet. Now we know that the thoracic inlet is the superior thoracic aperture, the upper opening of the thoracic cage, and forms the important area of passage of vital structures from the neck to the thorax. And if you can see over here, there could be a lot of difference and compromise in this thoracic inlet whenever there is a deformity of the spine involving this region. It need not be an actual deformity of the cervicothoracic region, but the deformity can be higher up in the cervical spine, or it can be lower down, but the spine can be involved in a huge compensatory lordotic curve, which actually severely compromises the distance between the sternum and in the cervical and the spine, causing a distortion. Now, this could affect a lot of physiological process, but these effects have not been studied very carefully. Because when you have an alteration in the chest wall rib vertebra complex, it will lead to thoracic inlet narrowing, and does that lead to cardiopulmonary dysfunction. Now, our interest in this area actually started off with this case where you can see that he has got a very severe cervical kyphosis. Clinically, you can see that there is a huge kyphosis over here, and the entire thoracic spine was converted into a large lordosis. A 135 degrees kyphosis in the cervical region with a 105 degrees lordosis at the upper thoracic region. Now, this actually led to a severe compromise of the thoracic inlet, as you will see. And as usual in all these huge deformities, which we can term it as a buckling collapse, you can see that multiple levels, the facet joints are completely dislocated. Now, our idea of this surgery was that we would loosen and straighten the curve as much as possible by a halo gravity traction, which we applied for 3 weeks. And this was quite useful to reduce the kyphosis to 84 degrees. Subsequently, we did a first stage anterior surgery where there was an anterior release, there was a corpectomy done, a temporary spacer was placed, and then the drama started. When in the second stage on the same day, we planned to do a posterior column shortening osteotomy and deformity correction. So the patient was placed prone, and immediately over a period of 1 to 2 minutes, there was a slow and sudden onset of bradycardia and hypotension followed by complete asystole. And so the patient was immediately turned for resuscitation, but we found that the heart rate became normal and slowly returned everything normal immediately on turning the patient to supine position. After stabilizing the patient, 2 additional attempts were made on placing the patient prone, and every single time, within 2 minutes of placing the patient prone, the patient had slow bradycardia and asystole. So the surgery was abandoned, and an analysis of the CT and MRI was done, and we found that there was a severe restriction of the thoracic inlet, which we had not taken into consideration before the surgery. Now, this was supposed to be the cause for this phenomenon because we know that the right thoracic inlet, we found that it was very severely narrow, and prone position actually caused a further dynamic compromise. And because this is the location here of the right vagal nerve, and we know that the right vagus nerve supplies the sinoatrial node, which is the natural pacemaker of the heart. And the pressure of the medial end of the right clavicle on the vagus nerve caused a sympathetic inhibition, resulting in sudden parasympathetic overtone, leading to bradycardia and a complete asystole. Now, in physiology, this phenomenon is well known and is called the Basal-Jarvis reflex, a subtle irritation of the right vagus nerve leading to a complete asystole. Now, once we realized this phenomenon, then we went on to this, another attempt where if we planned that when the patient is placed prone, if there is a Basal-Jarvis reflex occurs, then we will do a thoracic inlet decompression and then we will proceed with surgery. So this is exactly what happened, and we then went on to excise the medial end of the right clavicle. And once this was done, it was possible to place the patient prone without any change in the cardiac status. And then a posterior deformity correction was completed. And this was the excellent result that he had from 126 degrees to 45 degrees. And you can see the excellent result that he had. Now, this case actually led us to do some literature search. And we found that there was a lacuna in literature on the effect of narrowing of thoracic inlets. And we wanted to find out whether this narrowing correlated with the thoracic cage parameters and also the pulmonary function. So the study was done in Ganga Hospital. So the idea being to correlate curve characteristics with thoracic inlet measurements and pulmonary dysfunction. And we wanted to find out whether the calculation of a thoracic inlet index will be good in predicting pulmonary dysfunction. So this was done between August 2017 to August 2018, a one-year study done prospectively in Ganga Hospital. And we included all cases above the age of 8 years, cervical and thoracic scoliosis, kyphosis or kyphoscoliosis, and the deformity had to be greater than 30 degrees. And these were the exclusion criteria. We divided the patients into three groups. Group 1, which had 31 to 50 degrees. Group 2 had 51 to 80 degrees. And Group 3 were cases which had a deformity of greater than 80 degrees. In all these patients, the thoracic inlet index was calculated. Now, this is a very simple calculation which can be done on the MRI in a cut that is taken at the uppermost level of the sternum, in the axial cut. So you do a transverse diameter, which is the maximum transverse diameter between the bony margins at uppermost sternal level. And the APS measurement was the maximum anteroposterior distance between the vertebra and the sternum at the same cut. Now, the inlet index was a ratio of the transverse measurement to the anteroposterior measurement. Now, this is a very simple measurement, and you can see that it can be done in the MRI, which is usually done as a preoperative assessment for these patients. There was no need to do any further investigation, and also there was no need to do a CT, which often increases the radiation to these young patients. So once this was calculated, this was correlated to many other rib cage parameters as transverse thoracic diameter, hemithorax height on concave and convex sides, concave and convex apex to rib distance, and AP measurement at the level of the manubrium. Now, these are all the normal radiological parameters which are used for in the calculation of the effect of the deformity on the pulmonary function. And for the calculating the pulmonary function, we did the three tests, and it was divided into these ratios depending upon moderate was between 41 to 51, mild was between 60 to 79, none was greater than 80. But if there was below 40, it was considered to be a severe restriction of the pulmonary function. Now, these were the controls which were also used to find out. And you can see that we had 80 patients and 20 controls, and the mean age of 14 years. 70% of them were females and males, and the etiology of the curves are shown here. Most of them were congenital or idiopathic, and there was between these two groups, it was equally distributed between 2 and 3. Now, group-wise distribution was that we had 6 patients in group 1, which is that the deformity was between 31 to 50 degrees. The majority were in group 2, 70% almost, in deformity of 51 to 80 degrees, and 24% were severe category, which was more than 80 degrees. In the coronal plane, the maximum deformity was 114 in one patient, and in the sagittal plane, the maximum deformity was 109 degrees. Now you'll find that the thoracic inlet values correlated a lot with the nature of the deformity. Now in the controls, the maximum deformity was thoracic inlet index was 4.14 and minimum was 2.35. Whereas in group 1, it was, you can see that as the deformity increased, and group 3 is the group that had a deformity of greater than 80 degrees, you could find that the maximum was 7.35. And this actually correlated well with the pulmonary function. You can see that as from controls to group 1 to group 2 to group 3. And in group 3, the maximum was 7.35 from with the average of 3.94. This is actually showing the same values and how it increased with increasing deformity on the thoracic planes. Now you can see that the distance between the vertebra and the sternum in controls is so huge compared to what can happen when there is a huge lordotic compensatory curve at the same level when there is a huge deformity. Now, we did a multivariate analysis on what were the factors which affected the pulmonary function, and apart from the curve parameters of increased kyphosis, a upper level kyphosis, and an apex proximal to T5, we found that one of the things which was significantly affecting the pulmonary function, correlating, was a thoracic inlet index of greater than 5.6. Now, if you had a thoracic inlet dysfunction, and if your indices was more than 5.6, you had a moderate dysfunction, and if it was more than 7, it was a very severe dysfunction. So here we had an opportunity that just by doing the MRI, which is normally done as a preoperative assessment, and by doing a calculation of thoracic inlet, we were able to predict a moderate pulmonary impairment if the inlet index was greater than 5.6, and a severe impairment if the inlet index was 7.1. And it correlated very well with the clinical predictors of tachypnea, accessory respiratory muscle use, and also the radiological parameters. So this indices, we found it to be very careful. Now, when we went back and saw what is the literature spread on this important topic, we found that there was a lacuna. So there were only case reports, or most of them were assessing by CT based, which is not very ideal in these young children of the problems of irradiation and an additional cost just for this. And we found that in patients who are very young and who may not cooperate for a PFT, then we can actually look at this as one of the indicators for pulmonary dysfunction. So we thought that this study was quite useful, novel, because it correlated the thoracic inlet distortion. anatomical entity, an anatomical measurement which has not been very much used routinely in our clinical practice. And what is important is that it can be calculated from MRI and it avoids the use of a CT base. Of course, there is a limitation of the study, but we had a huge sample size of 80, and we need to have a packs and perfect cuts to have the perfect calculation. But I think that this is an important tool that actually to bring a focus of us in the use of these in patients who are greater than 8 years, and it predicts the impending pulmonary impairment. So when you find that the index value is greater than 5.6, then we need to be very clear about the pulmonary function problems that it can happen. So this is one index which will help you to get a good idea of pulmonary function at no additional cost and no radiation. So if you have a problem of bradycardia or alteration of heart rate when you are actually positioning the patient prone, we need to be careful and check for whether there is a dynamic inlet narrowing and whether there is the phenomenon of Basal-Jarvis reflex. So thank you very much for the opportunity to discuss